I said I'll save some time by coming up here. The topic of my talk today is my experience with TAVI from inception to current practice, a case-based learning. And of course, the topic is so vast that we could all discuss a number of cases and a number of learnings, because learning is a continuous process. But for the purpose of my talk today, I'm going to talk about my experiences learning from inception, which is going to be a throwback on the past, some aspects and learnings about the choice of valve, looking at younger patients as well, and what are my learnings from the younger patients. The bicuspid aortic valve, of course, is an important subgroup of patients in our subcontinent. And finally, of course, the important valve-in-valve, the growing number of patients that we have from in this group. Well, I think the throwback, and from its inception, really goes back to the first in-human study. The first core valve in the world was implanted in India. And that was the first successful core valve implant in the world on 2nd August 2004 in a patient with aortic regurgitation. As you can see here, that's Laborde, and that's Jacques Seguin and ourselves. And that was this patient who actually underwent this implantation. And you can see this is aortic regurgitation, severe aortic regurgitation. The valve, very similar to what it looks like today. But it was lassoed across into and pulled across into the valve. It was opened in much the same manner as it is today, 18 years later. And then this is the final result. And as you will note, absolute disappearance of aortic regurgitation on the table. We still worry about aortic regurgitation. We still worry about paravalvular leaks in the present era. But that was a zero aortic regurgitation in those times, probably related to the shape of the valve itself. And I think that was an era, it surprised us completely, started the era of of self-expandable valves. Well, there was a delay in the approvals from there on after the first in-human study for its use on a commercial basis till we, on 22nd February 2012, after persuasion of the government, introduced it as a special access for the first commercial use in India. And that led to, of course, our experience in the high surgical risk patients, proceeded to conscious sedation that very year. And of course, that first patient, the first of the 3 patients who underwent commercial TAVI in the country, happened to be, that was the 10th year anniversary of TAVI now in this country. And this gentleman lived till 2 months ago for 10 years. He had it at the age of 82. He lived to the age of 92, one of the first 3 cases in the country. Well, what are the humbling and sobering learnings? Well, just at the time that we were getting on the 20th patient, feeling that we were very confident of what we were doing, we thought we knew it all. There was certainly a set of complications which we'd never had and never knew how to handle, because this was totally afresh, was the death of patient number 20 due to a wire-induced perforation. And then, of course, one realized that you had to continue to learn on this device. We went on, of course, gained further experience through, and of course, had a number of publications related to transcatheter aortic valve implantation. But the next important step in this country was the creation of the indigenous balloon expandable MyValve. And I was privileged to be the principal investigator of the MyValve 1 study, which we presented at the late-breaking trials at the EuroPCR with a simultaneous publication. And of course, the first the percutaneous transaxillary access, as we progress to alternative accesses in those with the highly stenosed or diseased iliofemorals. And this is truly percutaneous, per-closed proglide, and you can see the puncture site in the axilla. This was a great approach till, of course, we started doing intravascular. We had intravascular lithotripsy available to us. And of course, femoral approach then became the standard, continued to remain the standard of care for almost all our patients, even those with highly diseased iliofemoral vessels. So if we were to talk about where do we stand in India today, we are actually talking about 230 hospitals having performed TAVI. Across 45 cities, more than 50 hospitals have performed 10-plus cases over the last 2 years. But truly, there are only 6 centers which perform more than 75 TAVIs over the year. and we expect to do 2,000 TAVIs this year as opposed to 1,200 last year. When we look about our last 100 cases earlier this year, performed between January and October of 2022, we have a mean age of 72. This needs to be understood in the context of international data. Bicuspid valves from 27% of our patients, self-expandable and balloon expandable in our practice are more or less equal at 55 and 45%. We recently introduced cerebral protection sentinel device and have started using it in more than 50% of our patients who can actually afford the device, and we certainly promote and encourage the use of this device. Device success has been 100%. It's all been 99% of these have been conscious sedation. Stroke rate disabling at 1%, permanent pacemaker implantation rates at 11%, and mortality at 1%. But let's review the choice of valve. I think that's a very important aspect which confuses a lot of people. We have these currently available devices in the country. Which device for which patient is always the question. We have the balloon expandable, my valve from Merrill Life Sciences, made in India, encourage that, and the Sapien, Edwards. We have, of course, the Medtronic Evolute R Pro and the Pro Plus, which is going to be introduced very soon. This is a supra-annular device. The Accurate Neo from Boston Scientific, introduced by us again 2 months ago, a supra-annular device. The Navitor from Abbott, intra-annular device, and Hydra from Sargent Medical Technology, a supra-annular device. So if I was to tell you in general, this has to be understood. There's not one device type. One device cannot fit all. And the guiding principles around self-expanding valve, in my experience, are that Evolute Pro has the longest durability data for the moment, Evolute R and Pro. The self-expanding valves, of course, have the lowest low profile. Evolute Pro has the best opening radial strength at the moment, and certainly advantage in highly calcified anatomy. I certainly favor supra-annular valves for small annuli, for valve-in-valve, for bicuspid aortic valves, and also for small iliacs. We need to understand that for tortuous anatomy, of course, Accurate Neo, Navitor, and Hydra are more flexible and allow better coronary access. But when we get to balloon expandable valves, they are easier to implant, great for horizontal aortas, but I certainly advise caution in heavily bicuspid aortic valves with calcified raphe and outflow tract calcification. My valve, of course, provides tailored intermediate sizing, which leads to ease of deployment, accurate implantation, and of course is made in India, so I do encourage it, and of course it allows easier coronary access. One needs to understand, and this just into perspective, two cases done on the same day, a 72-year-old male, tricuspid aortic valve stenosis, planned for Evolute R, 26 millimeter, based on the fact that he was 72. And a lady, 86-year-old, who was planned for a 24.5 millimeter my valve, again a tricuspid valve with severe aortic stenosis. This was a decision based on their preferences and less on their anatomy, but as we moved ahead to the anatomy in a heart team discussion, the patient number 1, who was planned this just moved ahead, who was planned for an Evolute Pro, actually had, let me just move back. Yeah, and he had low coronary austere heights. So instead of a 26 millimeter Evolute R, we chose a 23 millimeter my valve, and as you can see, implanted it slightly low, had zero gradient, had no conduction defects, and the patient did well. The 86-year-old lady who was planned for a balloon expanded 24.5 had smaller iliacs by 5.3 into 5.5. We could push perhaps a 23 millimeter valve through it, but a 26 millimeter valve would be very difficult. There was no need to take chances on that, so we implanted an Evolute R Pro 29 millimeters and got a great result in her as well with no conduction defects. What I mean to say is you can't be a one-valve person, and neither should you be a bazaar of valves trying to implant all valves. We have choices for valves which are suitable to a patient's anatomy. There's no heroism into pushing the boundaries just to show that it could be actually done. Perhaps shove our 18 French sheath for a balloon expandable valve going through a 5.5 French iliacs. It's not about how slick you are, it is about how safe you are. And we need to be a spokesperson for the patient and not the valve. Let's talk about the younger patients. I think an important area. It has been an area of emphasis of guidelines more so recently after, of course, the low-risk trials came out showing equipoise or even superiority of TAVI over surgical aortic valve replacement, and therefore a number of younger patients, and I would say not young, but younger patients, undergoing TAVI. We need to understand that while in the West we talk about less than 75 and more than 75 in terms of the guidelines, we must remember that the life expectancy of Indians is 10 years less than the West, and therefore our patients are never going to go through 3 procedures like a surgical aortic valve replacement, or a TAVI first, then a surgical aortic valve replacement, then an explantation, and then a TAVI. We are actually, in our own lifetime, we believe our patients will need a maximum of 2 procedures. And therefore, we actually therefore believe, and the important aspect, of course, is that the patient-prosthesis mismatch is a real issue. Mortality is higher in those with moderate patient-prosthesis mismatch, and I think it's an important area of understanding the fact that it is totally unfair to implant a less than 23 millimeter balloon expandable valve in any patient, because we will actually, in most instances, especially with a body surface area beyond 1.6, would actually have a moderate patient prosthetic mismatch. I think that's an important area to understand. We feel that this is an important aspect, at least of my priorities of TAVI in younger patients. I would consider a balloon aortic valve, I would consider a SAVR in bicuspid aortic valves less than 65 years. I would consider a SAVR in low-risk TAVI patients, in low-risk patients under 60 years. But above this, I'm clearly in favor of transcatheter aortic valve implantation, but I would clearly, in this order of preference, aim for durability. I would then aim for limiting major stroke rates in these young patients. I would definitely try and avoid prosthesis patient mismatch and get the largest effective orifice areas. I would endeavor to keep my pacemaker implantation rates lowest, and coronary reaccess is not such a major issue to me, especially if the coronary arteries have minimal disease process. So if the risk of coronary occlusion, but the only time that I would encourage a less than 23 millimeter balloon expandable valve like a Meyer valve is a patient with higher risk of coronary occlusion, and the patient has intermediate risk for surgery or refuses surgery. And that's the only reason to put in a small balloon aortic balloon expandable valve, where we sacrifice prosthesis patient mismatch for safety. It's very important to understand this, because occlusion, coronary occlusion, is death on table in 50% of the patients. We don't want that. So here's a representative case. I did this live on Hyderabad valves. My valve, 20 millimeters, small root, small sinuses, low STGA, low coronary height, great chances on absolute likelihood of coronary occlusion, especially if you put on a 23 millimeter evolute, because the sinuses are sequestrated at 24 millimeters and the coronary height is at 9 millimeters. Well, my valve 20 millimeter, absolutely a moderate prosthesis patient mismatch, but this is the time to put it in. Here's, of course, a proper coronary protection, as is seen here. You have to go full out. And once you do that, you actually have the valve implanted 70-30, so that you save the coronary. When you save the coronary, you actually see that you have a 26 millimeter residual gradient. That was expected. You actually have a patient prosthesis mismatch right here. Post-dilated with extra 1 ml on that 20 millimeter valve, as is seen on the left side, you decrease the gradient down to 14 millimeters. Now you see that the sinuses are totally sequestrated. There is absolutely no sinus left, but the coronary blood flow is maintained. The access to the left main is fine. The patient gets discharged, and this is the only time that you accept a moderate patient prosthesis mismatch. Of course, we make sure that we have commercial alignment in these young patients, and we do as best as possible a cuspal overlap, especially with evolute, to make sure that we have the least or the optimal depth to avoid permanent pacemaker implantation rates, and we can get it as low as 10% with our endeavors. So In TAVI and Young, it's a guiding principle. It's an important responsibility to understand and improve the lifetime management of a patient with aortic stenosis rather than just getting him discharged without a complication. Bicuspid aortic valve, we have a number of publications related to that. I was privileged to be a part of the roadmap towards standardization of transcatheter aortic valve implantation in patients with bicuspid aortic valve. We have published our 2-year data of 2 centers as experience from India. But what we are aiming for in these patients is making sure large, effective orifice areas. Yes, I'll just take a couple of minutes because I know one of the speakers is not here. Dr. Goel, one of the speakers, Dr. Ziad Ali, is not here. So I'll just take a couple of minutes. So 63-year-old male, severe aortic stenosis, bicuspid CVOS type 1. And if you see, he's got normal coronary arteries, but he's actually got a very small sinus annulus. If we take a balloon expandable valve, it's a 21.5 millimeters. But if we take a self-expandable evolute art, it's 26 millimeters with 23% oversize. But then we give him good effective orifice areas. And like I said, I not put in a less than 23 millimeter balloon expandable valve if I can. And of course, this 26 millimeter evolute pro gives us initially a peak-to-peak gradient. So there it is. And you have a 6 millimeter peak-to-peak gradient in that small annulus, and you actually have no patient processus mismatch. That's what we want to give with supraannular valve in bicuspid positions. Finally, learnings experience from valve and valve is this starts off with this terrible case of a 66-year-old lady with a degenerated 21 millimeter perimount bioprosthetic heart valve, in which we do a pre-dilatation with 4 into 16 millimeter balloon, which leads to a crash on the table and an incessant VT-VF storm related to severe aortic regurgitation on the table. The leaflets just tore. Numerous shocks did not relieve that incessant storm, and the patient was put on ECMO within 7 minutes. The valve was then deployed. You can see on a standstill heart, the ECMO stopped for a moment, cardiac massage going on, and that is the transcatheter valve deployed after that. That led to at least a relief of and the recovery of the patient. Return of spontaneous circulation took 25 minutes. The myocardium was stunned, but we actually salvaged the patient, and a week later the patient was discharged after a tumultuous course. But what does that taught me? It said in the self-expandable, firstly, we use self-expandable supraannular valves for valve and valve, but we do not predilate the valve. But we need to get away from such understandings, as in 78-year-old male, 2005 degenerated BioCor valve with a very high STS prom score. And the inner diameter of this degenerated valve is 19 millimeters. He's got safe coronary ostia heights, but in this case, what was clearly the choice between a 26 millimeter self-expanding evolute R versus a balloon expandable 23 millimeters. But look at the usually aneurysmal aorta, the tortuous horizontal aortic route, which would have been impossible to get a 26 millimeter self-expandable valve evolute R across. It was difficult to cross in that huge aorta, a small valve sitting there. Finally crossed it, Lunderquist wire, broke my rule of pre-dilatation because it was a horizontal aorta, and this was only possible, as you can see, with a balloon expandable valve to be able to cross this horizontal small valve, bioprosthetic valve sitting in a huge massive aorta. Valve deployed, you can see a residual gradient of 40 millimeters, valve fracture done with an Atlas Gold 22 millimeter balloon, and you will see right at the end the fracture happening, and as it cracks open, the gradient gets decreased to single digits, and that's where it cracks open, and that gradient is decreased, and of course he does well. Look at the valves just sitting there in a huge dilated aorta. So my final message is, you can never learn enough. There is no simple case. There are no shortcuts to doing TAVI. It's not a heroic performance. It's not a competition, but it's a responsibility to a patient that we always have to lead. And a team huddle before the case and team debrief after the case is utmost important to giving the patients your best. And of course, finally, let me announce that we hope that you've got these dates marked for this 4th CHIPS CTO India meeting 2023, 27th to 29th of January. Be there in Delhi for this fascinating faculty which gets together to deal with advanced and complex PCI. And of course, we have India valves. on 1st to 3rd September 2023 in New Delhi. Thank you very much for your attention.